For patients with adenocarcinoma of the lung, we know that about 10% of all patients will have an EGFR mutation. Maybe 5 to 7, 8% are going to have an ALK translocation. Maybe 2% are going to have a ROS1 mutation. And those are the three that if we find a mutation, an actionable mutation, we know that starting with the targeted drug is going to be better than starting with chemotherapy. We have randomized phase 3 data for EGFR and ALK showing us that. For ROS1, it's a little bit less clear, but it's become a standard practice. However, we also know that patients with adenocarcinoma of the lung could have MET exon 14 skip mutations, could have BRAF mutations, HER2 translocations, mutations. And I've personally had patients in my practice with all of those less common driver mutations where we found it and been able to give them other treatment options with targeted approaches that we wouldn't have had for them if we didn't know. So I personally think it's important to test all patients with adenocarcinoma for a list of, it's about 20 genes now that could be potentially actionable. For patients with squamous histology, it's less likely that we'll find those. But in my patient population, which is a lot of patients who have very light or no smoking history, and a lot of patients who are Asian, we're finding those driver mutations even in squamous at times. There's also the issue of misdiagnosis. You can get a small piece of tissue and have it look squamous when really if you looked at a bigger piece, you would see it's mostly adenocarcinoma. So it's important not to exclude testing unless there's a reason really not to. If there's really not enough tissue, the patient has a heavy smoking history and they have squamous histology, it's not necessarily worth repeating the biopsy, at least early on, because the risk from the biopsy is probably a little bit higher than the potential likelihood of finding something that's going to change practice. But if a patient comes in and they've never really been tested or they didn't have much tissue and they have a very light or no smoking history or they have adenocarcinoma, your likelihood of finding something that might change your treatment option for the patient is going to be 25, 30, 40%. So it's really important to push to get that testing done. I think that the fact that she had the PD-L1 testing and she had the molecular testing is really important, and want to emphasize that because we are still seeing, even in the United States, patients like this coming in and not getting that testing done, and that really limits the ability to know what to do next. In her case, they didn't help guide us to anything other than chemo, but it was good to know that those were tested and negative. And then the decision for a platinum doublet, perfectly reasonable. This patient had a PD-L1 testing done at the time of her diagnosis. Assume it was with a 22C3 assay that would have allowed her to get pembrolizumab if the level had been over 50%. I do believe that for all patients with metastatic lung cancer, it's really important to do that testing now. We know that about 30% of all patients with lung cancer will have a PD-L1 expression level of greater than 50% at the time of diagnosis, again using the 22C3 assay. And if that is found and the patient does not have EGFR or ALK, we know that starting them with pembrolizumab can lead to a higher response and actually improve survival versus starting with a platinum doublet. So it's really critical that we do that testing for all these patients.